The pie in the sky idea for these studies is, first of all, why are adults getting cardiac events earlier with CP? That's number one. Number two, once you figure that out, so the first thing you got to do is recognize there's a problem. Then you have to figure out why there's a problem, and then you have to do something about it. So for me, it's all preventative care. If I had one dream, it's that this gets published in a cardiac journal and some preventative cardiologists look at it and say, hey man, we should run with this.
Welcome to another episode of Parálisis Cerebral Respuestas, or in English, Cerebral Palsy Answers. I'm actually very excited about this episode. It's a long time coming, and I at one point thought that it was not going to happen, but it's finally happening. So I'm very, very happy and actucited to interview my current guest. So anyway, let's jump right in. Actually, let me introduce my guest. So my guest is Dr. David Frumberg. I hope I said it. Did I say that right?
Yeah, perfect.
Okay. He is associate professor of orthopedics and rehabilitation at the Yale School of Medicine and director of the Cerebral Palsy program at the Yale New Haven Hospital, in addition to being co-director of the Limb Restoration and Lengthening program, also at Yale. Yeah, a lot. So thank you so much for accepting the invitation, Doctor. Like I said,
Sure.
I'm very, very excited to have you for 1 hour. There's so much that I would love to ask you about, but I have to be very succinct and focused. And just for a little bit of context to those that are listening or watching, I met Dr. Frumberg. Actually, I really didn't meet him. We've never really met. This is the first time we're seeing each other. I saw him present during the American Academy for Cerebral Palsy conference in Quebec City, Canada, which was my first. And I have to admit that I was a little nervous about it. I wasn't sure if I should attend or not because, I'm not a medical professional, and I didn't know if there was going to be something for me. Well, it turns out there was. And in retrospect, I'm so glad I went, because one of the highlights of my entire time in Quebec City was definitely seeing Dr. Frumberg present. He presented on two topics that I think don't get enough attention, much like any topic that has to do with adults with cerebral palsy. Women with cerebral palsy receive significantly less gynecological care. Let me start over. Women with cerebral palsy receive significantly less gynecological preventive care and cardiovascular disease with in adults with CP. I feel like I've heard your voice so much in the last couple of days, and I've seen so much of your work, of your body of work. In preparing for this interview, Doctor, I saw and read a lot of what you've been involved in, and I went online and I saw all the videos that are available at YouTube that involve you. And there I noticed just how much knowledge you have about all sorts of topics. I mean, what I mentioned in the introduction are just 3 things, but truly, I actually wrote it. Your areas of expertise include limb lengthening, osteogryposis, musculoskeletal infections, among many other things. And as I was reading your body of work and seeing these videos, something jumped at me. Well, several things. The first is that you are someone that is not afraid of adults and, in general, cases that are complex, that you probably actually thrive in those cases, that you are committed to finding a way to help adults with complex needs. That is the first thing. And the other thing, and perhaps the most important, that jumped at me is your love and devotion that you have for what you do. And actually, I pulled a quote from one of your videos because, like I said, I saw them all. And I quote, "Probably the most important thing I can do for people is to inspire them to do more, to get out there and believe in themselves. So, what I have been trying to do is put together a huge team that will not say no, that will not be a barrier." Again, as a person, as a woman with cerebral palsy, I deeply appreciate that. I deeply appreciate that there are doctors out there like you that are willing to take a chance on us. Because many times I feel like I am an afterthought. I feel like I have an expiration date, that I am some sort of damaged goods. But there are people and doctors like you out there who take care of people like us. And I can't help but wonder, doctor, what is it that led you to become an orthopedic surgeon? And not only that, but to specialize in children and adults with CP, because you could have stopped at pediatric orthopedics, right? But you didn't. And instead, now you're one of the few doctors in this country who specializes in care for adults with CP. You're one of the few that leads one of the few programs that provide care for adults with CP. So please tell me, what is it that inspired you?
Well, that was a very kind introduction, and I'm so glad that I have a fan club of exactly one person now, so that's pretty sweet. We're growing. Yeah, no, I mean, thank you for having me here. It's fun to talk about just things like this whole field of adults with CP. Like, there's no science, right? It's all people doing what they think is right, and how many of those people there are, it's kind of hard to know. But like when an orthopedist is teaching you about cardiac disease and gynecological care, that's like that goes against every medical joke ever made. Like orthopedists are supposed to be able to swing hammers and that's about it. But the truth is that there's just no one looking at the stuff. I take care of so many adults now with various neurologic conditions or other conditions, post traumatic, whatever, and they don't have anyone else to look at this stuff. So someone will make an offhand comment in the office, or I'll say something like, have you ever been to the gynecologist for a routine exam? And they look at me like I'm crazy. So that's the only way that these things kind of um, they become studied. You see someone and you mention something. um, yeah, I don't know. I mean, it's a long story, but just to make it shorter, it always starts with a loved one. So, if you have a loved one or someone who you care deeply about who has some kind of disorder, and maybe you want to understand it a little bit better. And then if that loved one just so happens to go from being a kid into an adult and doesn't have any care at all for his or herself, then you feel like you need to fill the void. I mean, I certainly didn't go into orthopedics to take care of people with disabilities, but boy, am I glad I ended up that way. I went into orthopedics to take care of like big bone cancers and like try to take those out and then reconstruct them, restoring function and things like that. So, ultimately I ended up in this place and it's been extremely rewarding. I mean, it's not just that um, it's been fun to try to figure out what the right thing is to do with folks. I mean, I've done some really great surgeries and things like that, and I've done some really bad stuff too. I mean, like not trying to harm someone. It's just some things don't work. But if you don't have any research and everyone's being told that there's nothing anyone can do, and they're at their wits' end, I mean, you got to maybe try something if it's not going to harm somebody. But I think the ultimate goal is that like there's a few people who take care of adults and it's a little bit of a one-off, but it's not really its own field. So if anything, I think we've accrued enough experience now where we can start to try to inspire others to really like do neuromuscular adult orthopedics. There's so much function that is either lost or wasted because there's no one to care for these individuals. So that is a long answer. I don't know if I even answered the question, but
No, no, it's actually it's short, but I really appreciate it. So it started with a loved one, and then sort of that was what.
yeah, and then saw the void in there's a lack of care for adults.
Mhm.
So, you can go two ways with it. I mean, I sort of always knew, and that transition point into adulthood for the person I know, that happened when I was an orthopedic resident. So I'd already committed to orthopedics. I actually didn't even know you could do orthopedic surgery for people with CP. Like I had no idea. And I knew this person. And then like I think I just made that realization halfway through residency and I decided to go into pediatrics at that point because I thought it was really fun. And then I did a pediatric fellowship really to learn how to take care of people with cerebral palsy. I did that in Denver with two guys who were just instrumental in teaching me that stuff. There's one guy named Frank Chang who is now retired. Um, and then the other guy was Jason Rhodes, who is still active in the CP Academy's big gate guy engineer. So I kind of got to see there were two different views of how to care for kids, like Jason, I mean, he's more than this, but this is how he was for me, like what I needed in my life. He was the engineer. This is what the gait data shows, or the non-ambulatory child. This is what would be best for this person. Very scientific, very engineering minded. Still very ingrained in people's families. Chang did a lot of that stuff, but Dr. Chang was more all about um, like problem solving and being embedded in a family and more of like a gestalt. Now, so they both do both things. We all are multiple people. What I took out of my time under their tutelage was those two different things. Frank, it was like, how much fun can we have in clinic today? He always had stamps. That was like his thing. Kids would know that when he was there, he had a couple of different stamps and he would like give them a stamp. Just a silly little act, but kids look forward to it. And you weren't going to see a doctor. You were going to see Dr. Chang. It was different. You weren't gonna get a shot. Maybe you were actually. So a lot of times like, he's got Botox and stuff. But you wasn't the classic like, oh, I'm going to the doctor, another one of these things. It was like fun.
Mhm.
So I went there and learned really how to take care of folks with disabilities. And then this other hat I wear is limb deformity,
Mhm.
which would be using pretty crazy techniques like, cutting bones and growing new bone and filling bone voids. And they seem on the surface like those two things don't align, but actually the knowledge of limb deformity stuff is very useful in treating adults with CP. I'll give you one quick example. I know we're not really talking orthopedics here, but
Yeah.
it's just nice to be able to apply things.
Uh-huh.
You can cut it all later. I'm just gonna
That's
talk.
fine. No?
So, like, for example, let's say a kid has a knee flexion contracture. Or let's say a diplegic child, so someone with both legs are both affected, and they have a type of walking pattern called crouch. So, crouch gait, it's this disorder where, classically your knees are bent, your hips are bent, and your ankles can't maintain your legs upright. So your ankles usually going forward, like dorsiflex. And the idea there is that your center of gravity is falling in a it's not advantageous. So your center of gravity is like in front of your hip, behind your knee, in front of your ankle, where the human body was really designed to do the opposite. So if you try to walk around with your knee bent a little bit, you start to feel the burn in your quads after a
Mhm,
little while. And so
mhm,
if every time you went to walk, you had to put your muscles at such a disadvantage, you'd probably stop walking. And that's what we see happen with a lot of the severe crouch. So if you're a kid, then you're probably going to get like either something to extend your knee. If you're still growing, you could gradually guide the knee into extension. If you're sort of done growing, you could do a bone cut and extend the femur. Well, if like we do that with a plate and screws, then and you're a kid, you'll heal it. But if you're an
mhm,
adult, maybe it won't heal. Maybe the biology is totally different. Maybe you have some
mhm,
other underlying disorder that's going to make it very hard for you to heal, and you'll have to stay off your feet, and like you'll get debilitated, or your constipation will come to the forefront, or like there's all these other problems with taking care of adults, and we're
mhm.
just starting to understand it. So, very long answer for it.
I was gonna ask you about these going back to these state of the art surgical methods that you use. I found out that you use these, please correct me. Um 3D fixator.
Yeah, so external fixators are these so like let's say you, God forbid, broke a bone,
Right.
and you have two options. You put Okay, go ahead. You're gonna
Wait.
say no?
So before I forget this, there's these techniques and you use, if I understood correctly, it has a Russian name.
Ilizarov.
Zilarov,
Yeah,
right?
pretty good.
And but there's another method I found out. There's this Wagner method?
There are multiple Yeah, those are all different kind of like, bone stretching and things like that. The truth is that has a somewhat limited role with CP because it it's hard to have a fixator on. And so like it's pretty rare to actually use that in CP. I use it for some of the complicated foot things. There are some adult conditions that definitely do better with that because if someone has such a bad contracture and you
Mhm,
could, let's say, I'll give you an example, right? Like a recent case. So someone has an equinus contracture, meaning that their ankle is pointed very far down.
mhm,
You have two ways to correct that,
mhm,
or not correct it, right? You could leave it alone. But you could either do something where you cut tendons and lengthen them until
mhm,
the ankle comes down. So you could do kind of like what we call an acute correction, where someone goes to sleep, you lengthen some stuff, their ankle's in a good position, you sew them up, you wake them up, and you're done.
mhm,
Or you could do what's called a gradual correction, where maybe you mount a frame, like a ring on their tibia and a ring on their foot, and you just very gradually stretch things out without making any incisions. So there's a role for each. In CP, it kind of depends on the person. A
mhm,
lot of times it's a little bit too invasive. However, some people are too sick to have open surgery, or it's too risky, or adults get these other things called nerve entrapment. So there's a lot of different things to consider, but those are all just methods of treatment. But it's not like the goal is to correct some problem, and how
mhm,
you correct it is a little bit different. I mean, like some those things can be painful. There's a lot of at least anecdotal evidence in our center that the pins and wires that go through your skin, they are very irritating, which can lead to more spasticity and things like that. So I actually don't necessarily use those for CP.
okay, that's good to
Avoid it.
know.
Yes.
Okay. I, for example, my pelvis is uneven. So you
Yep.
wouldn't use that You wouldn't try to lengthen. Um,
You could absolutely like length. Let's say you have one leg that's shorter than the other. You can certainly lengthen the shorter leg. The trick is that all the muscles, tendons, nerves, blood vessels, those also all have to lengthen too. And if you lengthen a bone and the joint above it or the joint below it is not completely stable, or even if it is stable, you can dislocate those joints. So it's like there's a lot of reasons to
okay.
weigh the risks and the benefits for sure.
Right.
Why a lot of times when someone's going to have a limb length difference and they have spasticity disorders, a lot of times we try to either stop their growth while they're growing so that the other leg can catch up, or you could just take a chunk of bone out and make them even. Yeah. So it's harder to stretch patients whose muscles really are not good, like as far as excursion goes.
Okay. Well, then
There
there
you
you
go.
go. That eliminates me as a potential um,
It's always possible.
patient. Um, but I want to actually dive into the research that you presented on at the conference, the American Academy for Cerebral Palsy. One of them, actually. If we had more time, I would definitely ask you about women with cerebral palsy and the fact that we receive far less gynecological preventive care. But I want to focus on the link between cardiovascular disease and in adults with CP. Um, I find that there's this common misconception when I tell people, right, that I have cerebral palsy, and it happens very often because I'm always moving around and I'm always meeting new people, whether it's in, line for TSA or in my local coffee shop or just people who stop me in the street and um, they're like, why do you walk like that? And sometimes I full on explain to them why, and sometimes I don't. When it's kids, I try to be more creative, but the reality is that I find that there's this common misconception that um at least in my case, because I say to people, well, it affects, I have spastic diplegia, it affects my legs, I have spasms and I have, you know, pain in my legs. And they're like, "Oh, okay, well, then it's just your legs, you're fine." CP only affects your legs and your mobility and your posture and I'm like, "Well, no, not really." The effects of cerebral palsy are far beyond just mobility issues and uh, motor issues, and they extend far beyond that, as I'm finding out now as an adult. And so, case in point is your research that there is a link between having CP and adults being at risk. Those adults that have CP being at risk of developing cardiovascular disease, right? So I want you to talk to me a little bit about that research and how are you conducting that research? Because I unfortunately come from my mother's side, come with all the women in my family have high blood pressure, um, um, diabetes, and high cholesterol. So when you're doing this research, are you taking that into account? The people like me, the adults like me that already have an increased risk because of genetics, right? And family history? Or how is it that you're conducting this research?
Sure. Yeah. I love this study um, because it's just shining a light on something that like no one's looked at. Maybe they have. I haven't read it though. This study was inspired. A lot of my research is inspired by work that's done by this one specific group. I'm like a huge fan of them as researchers, but it's the University of Michigan group. So some names you may see are Mark Peterson, Dan Whitney, Heidi Hapala, Ed Hurwitz. And I apologize if anyone's listening who's in that group and I didn't just list your name. But they're a really great group of people. They have an adult CP clinic and they have their own patients and they track them and they do very high quality research. The issue that I had was how can I possibly get, so the thing with research is all relies on statistics, at least if you're doing like quantitative research. So if I want to know what is the likelihood that someone with CP is going to get a heart attack, I have to find a certain number of people with CP and a certain number of people without. And then I have to track them and find who had heart attack and who didn't, right? That's actually very hard to do if you're, for example, just starting in practice. So I'm like 7.5 years into practice. There's no way I could possibly see enough patients to power a study like that. So for us, we have the ability to use a gigantic data set, and it's called Pearl Diver. It uses insurance claims data, but importantly has like Medicaid, Medicare, which is where a lot of patients with CP will have that insurance. So a lot of the other insurance claims data will not include state insurances. And so you get like a little bit of a skewed population. So by having all different insurances or uninsured even, right? Like those people generally without insurance fall under some kind of state claim. So we can capture almost everybody, we feel, or at least a reasonable sampling of people with CP. And then if we put that together, we can get hundreds of thousands of people. So I don't know any like this study that you're referencing. And remember that if a study is presented at the CP Academy, it's because it has not yet been published. So whatever I say, it's not been peer reviewed. But in this particular study, we presented 281 or 282,000 adults with CP. I mean, that's a tremendous population if you think about it. So I don't know any single institution that could possibly get that number of people. And that was just from 2010 to the beginning of 2022. So huge amount of patients. And then there's some methods that we can use to look at very specific things. And one of them is 1-to-4 matching. So we say we have a group of people. In this case, we define them as adults with CP using insurance claims data. We got 282,000, or give or take a few people. And then we match them. For every one person, we take their age, their gender, I think just age and gender, and we put 4 people with the same age and gender that do not have CP, and we put them, match them 1-to-4. So now you have 5 people total, like like each, whatever. I might be explaining this too much, but for the 282,000, whatever that times 4 is, that's how many non-CP people we included. And then we just compare the two. And so you can look at all the different things that have to do with cardiac conditions. Now, I am an orthopedist, so we had the help from Dr. Tony Pastor, who's a cardiologist here at Yale, and he helped us try to remember what all the different cardiac conditions are. But in this case, it would be ischemic heart disease, which is like heart attack or angina, heart valve disease, arrhythmias, atrial fibrillation, atrial flutter, cardiac arrest, and congestive heart failure. I mean, those are the huge ones. Now, so that's what we did. And we said, like, how many people with CP have it versus people without CP. Then what we did, we know there are some risk factors that you just mentioned, for example, genetics and things like that. There are some risk factors that people have, like eliminating CP for these conditions. And that includes age, gender, smoking history, hypertension, so high blood pressure, diabetes, cholesterol, and obstructive sleep apnea. So what we can do is then do what's called a multivariate logistical regression, where we control for all of that. So we take someone with CP who maybe has like diabetes and high blood pressure, and we take
Mhm.
people without it and we compare those two. And so we
Mhm.
we do this big model to figure out if you match people perfectly for every possible risk factor,
Mhm.
does their having CP alone make them more likely or less likely to have a certain condition? So that's what we did.
And I do, and please do correct me if I'm wrong, because I am purely going by memory, and this is something you presented back in October. But
Months ago. Yeah.
I if I recall correctly, you said that the factors that are that generally are linked to heart disease for the general population don't necessarily apply to people with CP. Is
That's
that correct?
exactly what we found. And I think that was like, for me, the big take home message. And I think one of the bigger take home messages for your audience is that even if you're not talking about, so if you're talking about heart disease, classically you think of like an old smoker who has diabetes and high blood pressure and all these like risk factors, right?
Hmm.
With CP, we didn't find that to be the case. We found that this was a unique condition. So the patient who has CP and gets heart disease, some kind of cardiac related disease, is less likely to be a smoker, is less likely to have some of these other conditions. Why that is, I don't know. That's for whoever is listening to figure out. However, what it means is when you go to the primary care doctor, if you're one of those adults that's lucky enough to have a primary care doctor with CP, then they should not just solely be relying on this research would imply that they shouldn't solely rely on your family history and your presence of these factors as the only thing that could cause heart disease.
Hmm.
I'm not saying just because you have CP, you're going to have heart disease. The research definitely showed that through multivariate logistic regression, that adults with CP were much younger when they had any cardiac condition by a couple of years. And the most important one was cardiac arrest. I mean, that was like 7 years younger or something like that.
Wow.
But also, CP alone had an increased odds for having that condition. Like, for example, cardiac arrest, someone with CP was 4.75 times more likely to experience cardiac arrest. Like, that's crazy.
Well, yeah, that's I'm about to turn 37 in a couple months, and um my birthday is usually the only day of the year that I really allow myself to celebrate. Of- Beyond, Christmas and all the other holidays, I really like to celebrate my birthday. But every day, every year that I get older, it's actually very scary for me when you just mention these things, right? And in addition, all my family history and everything that I have to be constantly in the lookout for, and the fact that there is a huge lack of literature, that also adds to the problem. Um, what do you hope to? Obviously, you just mentioned some data and statistics that are eye-opening, right? But what do you hope to accomplish with once this study is published? Um, what do you hope this study accomplishes or sheds lights on? And where I'm going with this is that, for example, I recently read that there are the World Health Organization doesn't have detailed guidelines as to the amount of exercise and physical activity that is required for that is ideal for adults with CP. It has released data for normally developing adults, but yet obviously you can't apply that data to individuals with CP. And I would even argue that there should be different guidelines for men and women because our bodies are different, right? Um, so what do you hope to accomplish with this study? do you think it might help create these more detailed guidelines, or what
Yeah.
can we expect?
Yeah, it's good. That's really great reasoning. And that's certainly something that comes up in the office all the time. Like people feel that if they can't achieve some level of exercise, that they're failing and they're doomed. Universally, that is not true. Like, yeah, you should exercise, sure. Without research, there's no one to tell you how much you should exercise, but there's also no one to tell you how little you're allowed to exercise. So that's fine. But either way, the pie in the sky idea for these studies is first of all, why are adults getting cardiac events earlier with CP? That's number one. Number two, once you figure that out, so the first thing you got to do is recognize there's a problem.
Mhm.
Then you have to figure out why there's a problem, and then you have to do something about it. So for me, it's all preventative care. If I had one dream to come from all this, it's that let's say you have guidelines that you should get like an echocardiogram at I don't know. I don't even know the words I'm talking about right now. I'm an orthopedic. But let's say adults are supposed to get like an EKG or an echo at some age. Like you should probably get that either at a younger age or with some other unique set of risk factors that you have. Now we know that CP in itself is a risk factor for cardiac disease based on this study. So that's probably enough for adults to get some kind of screening. I
Mhm.
think generally in the population, when like population level recommendations are made, they incorporate all these other disorders, but we know for a fact that like someone has a 4.5 times risk of having a cardiac arrest, you should probably get that investigated. So if I had one dream, it's that this gets published in a cardiac journal and some preventative cardiologists look at it and say, hey, man, we should run with this. And then someone else, much smarter than me, can figure out how to convert that into public policy. That would be my goal. For now, all I can do is preach to the people with CP, like, hey, man, no one's doing this crap for you. So get out there and go see a cardiologist or tell your primary care doctor. I mean, listen, it's a huge problem. You mentioned one of the other studies, which actually won the award for best adult paper, was about gynecologic preventative care. Every single person in this country would agree that women should have preventative care, gynecologic preventative care. That includes breast cancer screening. That includes gynecological cancer screening, things like that, regular routine exams. And for some reason, it's just not happening. And yet I can't get the OBGYN journal to publish that paper. So what's the problem there? Wouldn't everybody want to know? Wouldn't we want to shape public policy so that the women who are at a clear there's a clear healthcare disparity there. We don't know what the barriers are. Is it the workforce? Is it transportation? Is it
Mhm.
that women don't want to come get screened? All of these things are probably true, and there's a
Yeah.
lot of reasons for every one of them. But cardiac is no different, like I just seems like such an achievable preventative care goal that I just hope someone reads that paper and says, I'm going to make more out of this. So some grad student, if you're listening, you're looking for a PhD project, just do that.
You are already giving ideas. I'm very I'm glad you are. Um Going back to the reasoning as to I'm thinking as to why we are more at risk.
Mm,
Um I'm And obviously keeping in mind that every single case is different and that no two people with cerebral palsy are the same. And I can only speak from my own experience, but I'm thinking that the fact that, for example, I fall a lot. I lose my balance, and I've said it many times before. Walking is not my native language. Um,
I love that, by the way.
it doesn't come natural to me. I haven't quite dominated or the intricacies of walking, perhaps.
You're like,
And
hey, I can't get around too easily. I'm going to go to a conference that's on 3 different levels that covers a football stadium.
yes,
And
yes,
I'm gonna forget my glasses at the same time. So
and
yeah,
not see anything.
for that conference when it's busy.
Yeah, that was definitely a challenge. Um, I I love challenges. I think we have that in common. I love and I thrive in challenges. I every time I travel, the first thing I do is I learn the public transportation system of the country or the city that I'm going to because I don't drive. Um, I don't even have a driver license. And so that's my first thing, and it's always a struggle. People are like, "Why don't you just make your life easier?" I just don't have an interest in learning how to drive. But anyway, going back to my reasoning behind why perhaps we are an increased risk is like I was saying, I fall a lot, and um talking to my friends who also have CP, there's a sense of shame, right? Every time you fall. And there's a sense of embarrassment every time you fall. Um, and so that leads to having a more sedentary life, and not moving, right? And I'm talking about GMFSCS scale 1 to 3, right? I'm not referring to the fours and fives. But so I think that plays a big part in that the sense of embarrassment and the sense of shame every time you fall when you're walking. I mean, walking, that is something that most people learn very early on, right? I mean, I didn't learn to walk until I was like, what, 2, 3? But um, I think that is a big factor.
I don't know if you remember, but at one of those talks, actually, was I think it was my favorite research paper presented at the meeting. There was a woman who was talking about the psych. She was talking about a lot of things, but it was based on falling. She was talking
Oh
about
yeah,
and
yeah,
she was saying about just how embarrassing that is, and also how the general public doesn't really do know what to do. Like there's this natural assumption that if someone falls, you're supposed to pick them up or whatever. But maybe, I learned a lot about that. I think what you're saying is absolutely true. By no means is that the first time I've heard someone talk about that. And again, like sedentary behavior, it is what it is. And maybe it's a reason for cardiac function to decline or to have cardiac events. I do not believe that it is the full story by any means, because I
yeah,
think you have a lot of people who use wheelchairs who don't get cardiac disease. So, like, if it's always gonna be multifactorial, right? There's gonna
okay,
be many different reasons why people get cardiac disease. I think it's too convenient for somebody to say that if you exercise more, you wouldn't get a heart attack. Like, give me a
mm,
break. There's more reasons than that, right?
yeah,
Like, we can give medications to modify some risk factors. If you have high blood pressure, you can give a medication for that. If you, like, so there's, I don't know. I just think that there's a lot more that goes into it. I mentioned earlier I was talking about that Michigan group. They had an interesting study that I saw a few, maybe, I don't know, 7 years ago that showed that adults with CP had a higher rate or a higher prevalence of rheumatoid arthritis. And I don't know why that is, and I highly doubt they know why, but there's this concept that maybe there's this like autoimmune or neural inflammation. So there's something else going on in the body chemistry and the body composition of someone who has CP than just they're sedentary or their muscles are weakened or spastic or whatever. So there's a lot more going on in the body there than we know. Um, so we don't have this is what I'll say though. I do want to make this point to your listeners. We don't have research that says the best amount of exercise to do. We don't have research that says the healthiest habits to do. Like you open Instagram and all you see are people well, I don't know what your algorithm is, but all you see is people peddling like you gotta drink celery juice every morning and you gotta have turmeric in your mushroom tea. If it was so easy, then we would all live to 1,000, right? Just you know what's out there public health wise, and you know what moderation means and what
Yeah.
healthy habits are and things like that. I think all you can do right now is just do what we say to everyone who doesn't have CP. If there's some healthy habit that they have that you don't have, then maybe you should try for that. Now, understanding that exercise means a lot different things to a lot of other people. There's a ton of exercise science in the CP community. A lot of it
Mhm.
gets highlighted at the meeting. There's a physical therapist in Hartford, Mary Gennati, she'll take some of my patients and just do strength training. I mean, like there's a massive amount of improvement you could have. Not everyone can do it, and it looks different for everybody, but I think it's a lot of it is also mindset. So, if someone really thinks that exercise is going to prevent them from getting cardiac disease, and it's probably some mindset in that too. Um,
Yeah. There's
but
definitely multiple factors. I mean, there is like also the location where you live, the
yep,
access to resources, the fact that, a lot of people, and not only just people with CP, but people with disabilities have fixed incomes. And so that means something. That means that they only have access to certain foods and certain groceries. And that also plays a part. I'm sure that genetics in their families also is a factor for each of us. Um, I, but again, I'm not a doctor. I'm just thinking about um, the way that our identities intersect so much. And you've mentioned several times that you're talking about these terms, cardiac terms. You're not a cardiologist, but so I'll take it more to your territory. Um, how uh, how do cardiovascular health considerations intersect in your practice in orthopedic care?
in general, people come in and they have the same basic complaints as it relates to their musculoskeletal system and their cardiovascular system. The first one is fatigue. It seems with age, there is just this unrelenting advancement of fatigue. And we don't really know what happens and why it happens and what we can really do about it. It's very common. Some
Mhm.
people have strategies. That's been the case of a couple of the academy's webinars, which is nice. But pain and fatigue are just these like every adult dreads them because now there's enough research coming out that says that people generally get that. And I think if you're like a 20-year-old and you're looking at research, or let's say you're about to turn 30 and you run a podcast and you're preaching to people about this stuff, like you think that you're going to wake up one day and you're just going to be too tired. And that's kind of scary, right? It's like every other disease that we know is out there, or maybe it's in someone's family tree. However, I see plenty of people that don't have fatigue or that they modify their life a little bit to accommodate it. So I know that I'm really fatigued in the middle of the day. I'm going to do all my exercise in the morning. I'm going to rest in the middle of the day and I'm going to have a fun night. So some people can't really do that, but the people who can really be attuned with their body, it seems to be less of a stumbling block for them. The second
Are
thing is,
you
oh, go ahead.
are you well actually are you talking about just um regular folks with no CP? Because I have a
Oh, it's
lot of
people with CB.
okay, I have a lot of fatigue and I'm extremely tired. And I feel I don't know if this is possible, but in the GMFC I always get confused if I always get all the letters.
Well, in Spanish, you
Scale.
kind of flip words, right? So
Mande? What?
in Spanish, you like flip words too. So we give you a
Yeah.
pass.
Um, I think I'm like a sometimes I'm a 1 and sometimes I'm a 2 and sometimes I'm a 1.5 because sometimes I feel like I'm great and I can, walk and I can move and it's fine, but then there are days where the pain just sticks to my flesh and I cannot move. Um, so I experience a lot of fatigue and a lot of pain. And actually, I came across one article, and I'm sure you've read it as well or not. But I'm quite certain that you have come across these statistics, which I actually wrote down. And they are coming from a paper published in 2023, were called Adults with CP Navigating the Complexities of Aging. And it says that 50% of adults with CP experience a decline in daily functional activities by the time they reach the fourth decade of their life. So by the time they reach their 40s. And then another really um, scary statistic
Kathleen
for me.
Friel is the senior author on that article, I believe.
Huh?
I have read that article. I think that's Kathleen Friel is the senior author on that article.
Yes.
That's a fantastic read for people who are interested in long-term healthcare policy.
Yes.
That is a great article.
That is true. And Dr. Davina Kumar, I think, and
Yes.
Gabriel
Yeah.
Perez,
Yep.
if I recall correctly. And another very scary, actually, for me at least, statistic is almost 80% of adults with CP experience fatigue and severe pain. And I fall into those two categories.
Mhm. Yeah. Pain is most generally foot, ankle, or back. That's like the most common that an orthopedist sees for the complaints. But other people get, it's actually interesting. If you list out the symptoms, kind of sounds like when people talk about long COVID, minus
Okay.
like the respiratory stuff, although sometimes people do. But really, like the fatigue, the fogginess, the need to sleep, like can't even get out of bed some days. It can get very severe, and we do see that. And you can only imagine that those kinds of things are not very good for cardiac health.
And
And it's probably more than just the moving around. It's just like because you're even if you use a wheelchair, you move. Like people shift in their wheelchair. But if it hurts so much that your body just shuts down, your muscles atrophy, that's probably not very good. So there's got to be some strategy for that, you know?
right. And I'm sorry I interrupted you, by the way. We're going to talk about pain. Do you want to go back to that or?
No, it's fine. Pain, back pain, ankle pain. Everyone's got it. If you're listening to the podcast and you have back pain, ankle pain, foot pain, perfect x-rays, perfect exam, inexplicable pain, you are certainly not alone.
Hmm.
We just don't know. And I think that we don't know why it happens. Same with the
Hmm.
fatigue. There are a lot of theories. I think the one that makes the most sense to me is that the muscle is never quite developed typically. So it's like
Hmm.
a different muscle organ.
Hmm.
And the same way that I was talking about how adults with CP can get like more rheumatoid arthritis and they have these inflammatory problems. I think it's just we haven't really scratched the surface of what it means to in the natural history of CP as people go through adulthood. And it'll be kind of exciting, I think, because I don't know how many more years I got left to practice, like 25 or something like that. But I think we'll have some answers by then. Maybe not me, but I think there's enough people looking into it. We could always use
Okay.
more though.
Right.
Listening.
Well, actually, that's now that you mentioned it, this is a great segue to take a break, but that is something that I will ask you in the second part of this interview is, um, as I mentioned before, you're a professor and you're also an orthopedic surgeon, so you live and breathe in this environment. And I would like to know, are you seeing more students, more doctors interested in caring for adults with CP? We're back from the break. And in this part of this last section of the interview, God, time is flying. I wish I could stop time and just keep going, but I can't. Um, I want to talk, Dr. Frumberg, about your work, your day-to-day work at the Cerebral Palsy uh, clinic,
Yeah.
or I don't know, program at is it
Yeah, we have
something?
separate clinics too. When we have multidisciplinary clinics, which is
Uh,
like your classic place where there's many different professionals and it's never enough, right? But we have that for kids, we have that for adults, and then we
mhm.
have our own clinics.
Okay.
Yeah.
Um, and the reason why I want to talk about that is something that I mentioned before is that, there are very few of those in the US, and I would even argue around the world, because I've talked to doctors from mainly Latin America and Mexico, some in Europe. And the fact that there's lack of resources and care for adults with CP exists in those countries as well. So it's across the board. Um, but going back to your work in the program in those clinics, um, given that you specialize in adults and children and in all these other, you have all these specialties, right? I can only imagine that your day, no day for you looks the same. And in your program, in your clinic, you can see any sort of individual with also, GMFSC level 1 or 5 or all sorts of things. Um, how does your approach in care change depending on the complexity of the person that has the CP?
Yeah, that's a great question because every single person is different. Like even within the GMFCS, and especially by the time you get to adulthood, when you're an adult, you've probably had surgery or you take a medication or maybe not, maybe like someone just told you, maybe do I have CP? Some like it's everything. It could be anything. Yeah, I mean like the first thing is that you have to understand goals. Like a lot of times when I first started, people would come and see me because they thought they had to.
Mhm,
We came to see the doctor every 9 months or whatever it was, 6 months.
mhm,
So
mhm,
we're just continuing that, and there was no one to see us, so we're gonna do that here. And
mhm,
that was always really awkward when I would tell people like, "Okay, you can come back in 5 years." I was like, "What? What's gonna happen?" Um, there's not a lot of active surveillance that needs to be done for
mm,
adults. Now, I would argue personally for most kids don't need to see the doctor so regularly. Um, Getting to know people is a fun part of pediatric care. You really get to know families. The kids grow, you grow with them, you watch them grow, you all kind of like are in it together, right? For adults, it's not like that. I mean, you really
mhm,
can't. First of all, there's no growth. I mean, there are life events and things like that, and there are
mhm,
significant things, positive and negative, but um, it's not like I'm going to meet someone and say, I'm going to see you every 6 months till you die. That is not, that doesn't make any sense.
wow,
It's more important for me to try to understand what people are doing in their everyday life
okay,
and how they're participating. So in pediatrics, like let's say the most severely disabled child, that kid's got like a million doctors going to all these therapies, specialized
mhm,
schools, all sorts of things, right? And then all of a sudden it all goes away and you become an adult with a really complicated problem, or I should say, an adult with a complicated list of problems.
mhm,
And you go to the orthopedist because you got to check off the box. Like you don't need anything from me. I don't. No one needs to put your leg back on or anything like that. So that visit, the majority of that visit is spent trying to understand how this child is participating, and what I call demedicalization. So, like my best friend in the academy is this guy Nathan Rosenberg. He's a Nationwide Children's Hospital. He's a physiatrist, and we try to like get an Airbnb together at every meeting and we just kind of hang out at the meeting every year. We try to play hooky. I can't really do that anymore, but we would try to like leave and go hiking or something, and just talk about these bigger concepts. So one thing that we've come up with is demedicalization. So it's like less about how efficient your gait is or how your braces fit, things like that. And it's more like getting out into the world, or if you don't want to do that, how do you spend your day? What are you participating in? You don't need to leave your house to have an active social life, right? So everybody's world looks different. I don't even pretend that I can understand half of the things that kids are into, much less adults. But if you're happy, that's what matters. So there's this other paper that I'm sure you have featured called the F words. You know about that one? It's classic, and it's, like, perfect for adult care because those are all the things that matter. So whether I'm seeing someone who's young or old, it does or really complicated or not complicated at all, or just is there because they thought they had to check a box, everyone has this, like, life beyond the 15 minutes they're gonna see me, and understanding if there's any improvement that could be made, that's always beneficial.
Mhm.
Understanding if we can maintain what they have or if they're at risk for something in the future. Most people have goals, whether they like to admit it or not. Most families have goals. A
Mhm.
lot of the older folks we see, they're still coming with their geriatric aged parents, and those people still have goals for them. I mean,
Oh.
we talk a lot about goals and seeing if things are attainable. That's about it. But I think participation and not doing too much just because you come to see the orthopedist doesn't mean you need to like do something. So most of the time people leave kind of empty handed. Um, and that's a good thing. So,
I'm
but yeah, I
actually
think one thing you touched on though is that there's way too many adults with CP, and there's like one of me, there's one Hank Chambers, there's one, you know, so other people seeing adults. So how do we inspire the next group, right?
one thing that I often come across among my friend group is we don't know how aging and CP intersect, meaning that we don't know if we have pain, we don't know if it's CP or just normal part of aging. So how do they intersect? And are there ways, in your perspective and in your expertise as an orthopedic surgeon, are there ways to mitigate the progression of um, orthopedic issues in adults with CP?
Yeah, well, so that's the worst part about chronic pain and fatigue is that it interferes so much with your life that you come to this like intersection or inflection point. I don't know what the word is. And you're like, well, am I going to give into it or am I just going to ignore it and try to push through? And that's like a pretty unhealthy thing for anybody to make that decision. I would say that common things are still common. So if your tummy
Mm.
hurts, probably not your CP. It's because you're eating like food trucks or something. Um, but musculoskeletal pain, we do know, we still don't know why. The majority of the time that I investigate it, so I get an MRI or something like that, it comes up negative
Hmm.
almost always. And not only that, and that's anecdotal. I haven't studied that. That would be a good study, actually. I should do that. But not only that, like if I try to treat it, it gets better for a little while, and then sometimes it comes back. I mean, every once in a while, you see something like arthritis, early arthritis. That
Mhm.
kind of makes sense because the loading is not anatomic or whatever. But um, it's just so different for everybody. And I think until we have an excellent way to treat that problem specifically, then we just have to keep doing what you would tell anyone else.
Mhm.
So, functional use, there are physical therapy modalities that can be non-impactful.
Mhm.
um, they can meet you where you are. You just need to find a good physical therapist, and almost all of them are great. Um, some people may say that they only take care of like athlete, athletes or scoliosis or whatever it is, but they all did school. They all went into it because they wanted to take care of people, and you're no different than any other person, right? So if you have ankle pain, is it debility? Is it fatigue? Is it something that could be treated with an anti-inflammatory? Who knows?
Mhm.
You got to start somewhere. So usually I try to meet people where they are
Mhm.
and see if exercise really does make sense, what that would look like. Is there some very specific thing that may be causing an issue? It's always fun when you have like a 48-year-old person who's hated their braces since they got them when they were 4 and nobody's taking them off of them. So that's always fun. It's like you're 48, do what you want to do. I don't care.
Mm.
So anyway, there are some things that can be done, but again, these like aging problems are very tricky. And I would say get it checked out because you don't want to miss something that's easy to reverse. But don't be shocked if the imaging is negative and you maybe a little physical therapy goes a long way. On the note of physical therapy, kids get PT like all the time. Insurance companies give it out like water. Adults
Mhm.
don't get that. So I do not send adults for like maintenance PT. There's no evidence for it. It's something that families believe they need. I think it's a waste of time. I'd rather you take that time and spend it doing something you like. However, if you have no what not you, like if someone has no other way of moving their body or can't get help to get up and mobilize and have some edema control or pain control, whatever you're doing PT for, then you should do it on a regular basis. But if you're someone who can be a little bit independent and go out and do stuff, I don't think you should be doing PT every day just to do it. If, God forbid, someone is hospitalized with pneumonia and they lay in bed for 2 days, when they get out of the hospital, they should do PT, but not regularly. They should do like a burst of 2 days a week for a couple of months and get strong again. You don't want to lose things. So there's a huge role for physical therapy, but I think until insurance companies allow people to just get PT all the time, we have to use it strategically.
Okay.
But PT is definitely a good way to get things moving, especially if, like, when we came out of COVID, all the young adults with CP, they weren't doing anything,
Mhm.
and trying to get them moving again, they got a lot of physical therapy.
Okay. So definitely look into physical therapy, but it's not it's not something you would say, if I understood you correctly, you would say that
Yeah,
they should follow like by law.
you right. So, like, if a 4-year-old sees me in the office and they're not walking, that kid needs physical therapy.
Mm.
If a 4-year-old or even a 15-year-old has some kind of like hitch in their gait that maybe they need to get some more strength or something like that, they should do physical therapy. But even like teenagers, we're getting into a completely different topic right now, but I think it's going to resonate with you. Why are we just taking kids and like removing them from school and removing them from their peers and making their life be defined by a disorder? Like, stop doing PT. I'd rather you do, like, I tell kids all the time, like, don't do physical therapy if you do dance, if it's one or the other. So I don't know. I don't want to open a can of worms because we're like short on time right now. But I just think that kids and adults both need to participate. That's the most
Yeah.
important.
Yeah.
Like, you keep offhandedly talking about how you have these friends with CP. Like, you got friends, man. Like, were you all gonna go to physical therapy together? No, like out to dinner or
Yeah.
something.
Growing up, I remember that I hated going to physical therapy because it was in a very strict place, and it was always the same thing. And I was handed a paper, and the therapist would say, "Here, do these." Um, and since you brought up the issue with time, yes, we are very short in time, so I will skip one of the questions and go to the last question for
I'm
you.
gonna get so much hate mail from physical therapists right now, by the way.
Don't worry. I am gonna add a little bit of my own, so we can share that. But I mentioned that you are a professor, right? An associate professor of orthopedics and rehab. Um, do you see a change in terms of students being interested in caring for adults with CP? Do you see that? slowly there's more awareness and they're like, let's try adults and not just stick to pediatrics. And the reason why I asked this, the obvious question, the obvious observation is that there's a huge lack of medical professionals that care for, as we mentioned, adults. But also, I'm wondering if that is going to catch on at some point because I'm looking at statistics, for example, from the World Health Organization. And again, I wrote these down that says that by 2030, 1 in 6 people in the world will be 60 years or older. And then by 2050, the number will double to 2.1 billion. And then I was also looking at the birth and death rates, and I noticed that um, women are having less and less children across the board. You look at Japan and South Korea and Mexico and even the U.S. I think in the U.S. it's like 2.1 or something like that. And what that signals to me is that at some point, then there has to be able to say that you care for kids with CP is going to be a luxury, and that there has to be a change in that there has to be more care for adults. So sorry if that was very long-winded, but what
It's sums up the problem for sure.
what do you see in your day-to-day as a professor, as someone who, as mentioned before, you live and breathe this? Is there hope at the end of the tunnel?
Yeah, so it's a great question. I would say like 3 years ago during COVID, when we all were kind of just chilling and thinking a lot, um, I realized that it's unrealistic to expect the majority of people going into orth. So first of all, there's a national shortage of orthopedists to begin with,
Oh, wow,
right?
okay.
So it's unrealistic to expect some big group of orthopedists to say like, I am going to do a fellowship with Dave Frumberg in adult neuromuscular conditions, and that's going to be my practice. I
Hmm,
think it's probably unrealistic. So I kind of took the alternate approach where I think what we need to do is make care of adults with CP more accessible with just every other orthopedist. I mean, like every orthopedist can operate on somebody. That's really what you're looking for is appropriate care of injuries and traumas, things like that, infections, whatever. And
mhm,
then the occasional reconstruction that's needed. The majority of people, I would say like 90% of the adults I see in the office don't need any surgery whatsoever. So,
mhm,
like a physiatrist is a very good person for an adult with CP to know. And
mhm,
then those are very good people at intervening too and diagnosing and treating most of the problems that we have. I had a really nice moment a couple of years ago where one of my former residents who graduated took care of a gentleman who was a wheelchair user, GMFCS5, spastic quadriplegic CP. And my take has always been you should be treating them just like everyone else. Like most of the time, like someone who uses a wheelchair, if they break their tibia or something, they break their leg, they'll get put in a cast or something like that and be told to stay off it and then it'll heal and whatever. But everyone else would get an implant and get up on their feet again and move on with their life. But just because you don't walk doesn't mean that you can tolerate having a cast on or something like that. So you really do need the same musculoskeletal care as everyone else. There's been some movement, the Orthopedic Trauma Association, the OTA. I believe it was them. They released a statement about how people with disabilities should have the same access to orthopedic trauma care as everyone else.
mhm,
Um, and it's kind of along those lines. But I had a former resident who took care of a guy and was like really proud of it. And I think that is the more important thing. It's showing the general orthopedist, the guy who's in like the middle of Alaska or the person who's in the middle of the desert or nowhere near an academic center, like, hey, when you see someone who has CP and they had like a supracondylar femur fracture because they have a knee flexion contracture, do XYZ and keep them at home. Don't hospitalize them, get them back on their feet, and it's better for everybody. So I think if you can understand that people probably aren't going to go into adult neuromuscular orthopedics, but you can bring that to them, that's probably a better way to disseminate all of that. I think we're going to see a lot more research into it, I think, because there seems to be a group of people who recognize this problem. I mean, for me at this point, I'm doing more adult surgery than I am for pediatrics, which is totally fine by me because there's plenty of people who could take care of kids. And I mean, I think I could do it well, but I know that I could take care of adults pretty well. And I think that my time is better spent, quite honestly, taking care of people who can't go anywhere else. However, if some orthopedist or orthopedic trainee is listening to this and has some thoughts, as an academic orthopedist, I owe it to the world to let them know my thoughts, right? That's like what we do. So I think if we can somehow make the access a little bit easier for everyone, be it with even like our PA students. I have a PA student who I mentored, and she is now in San Diego taking care of kids with CP. It's like what she always wanted to do. She's going to see an adult. There's no doubt. And she's going to kind of have an idea of what to do and see that person as a person and not as a disabled adult, just as an adult. And that is the thing that we need to really strive to do more than anything. So it's more of like a leading by example and making the care more accessible for everybody. I think that's a more sustainable model. It requires a lot of like research and dissemination of information, which I guess we should probably start doing.
Yeah, well, you gave you gave two ideas of good research topics for the future, and I guess your approach and what you're mentioning is kind of meeting people halfway, right? Or an alternative way of just expecting people to all of a sudden have this moment and say, you know what, I'm just gonna focus on adults with CP. Thank you for that. That's it for today. Thank you so much for joining me in another episode of the Cerebral Palsy Answers podcast. And remember, if you have any questions regarding cerebral palsy in Spanish or English, please submit your question to cerebralpalsyanswers@gmail.com or head over to my website, www.azucenagarcia.com, and you can submit your question there. Thank you.